What we typically see is that if we treat them early, the responses tend to be better, particularly for patients with significant disability at onset.
Certainly, it's a very cost-effective therapy. The majority of patients remain off maintenance immunotherapy for the duration of follow-up, 5, 6, 7, 8, 9 years, and probably longer in many cases. We seem to see better clinical outcomes in people who have diversification of their T-cell repertoire, including their EBV-specific T-cell repertoire after AHSCT.
Well, I think the number of patients that qualify for first-line treatment is very low, but it's not zero. So there will be patients who have poor prognostic factors that will not do well on conventional treatment. And for those individuals, you can present this as one option. I'm Joachim Burman. I'm a neurologist at Uppsala University Hospital and a senior lecturer at Uppsala University Medical School.
My name's Dr. Jennifer Massey. I'm a staff specialist neurologist at St Vincent's Hospital in Sydney and a senior lecturer at the University of New South Wales Clinical Medical School.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. Autologous Haematopoietic stem cell transplantation, or AHSCT, is not a new treatment. However, in recent years, we've seen it gain considerable attention as a potential option in MS. Indeed, as the amount of long-term clinical trial data increases, there has been a growing debate about exactly how AHSCT should fit into the current MS therapeutic landscape. My guests in this episode, Jennifer and Joachim, have had extensive involvement in AHSCT research and trials, and in this episode we'll be discussing the latest findings and understanding of this hot topic. Jennifer, Joachim, thanks for joining me.
Thanks, Brett.
My pleasure.
So I guess to start with, for people who may not have a lot of background in this therapeutic approach, can you give us a quick description of what AHSCT involves?
So AHSCT, or Autologous Haematopoietic Stem Cell Transplantation, is a treatment that was originally used for hematological malignancy and has been applied now across a range of different autoimmune conditions over the last nearly 40 years. The procedure is performed in 2 stages. The first part is the mobilization of the stem cells. Historically, that was done extracting stem cells out of the bone marrow, hence the prior term bone marrow transplant. Now that can be done via a peripheral catheter, so stem cells are apheresed out of the vein. The stem cells are mobilized typically using a small amount of a chemotherapy called cyclophosphamide and a hormone that promotes stem cell proliferation and mobilization out of the bone marrow called GCSF. And then the second part of the therapy is the chemotherapy or the ablation itself, the transplant itself. And so for that part of the procedure, people are admitted to hospital and receive chemotherapy on a daily basis for a number of days, depending on the different chemotherapy regimens. And on essentially day 0, which is the day after chemotherapy finishes, people have their stem cells reinfused. And the idea is that the chemotherapy ablates the existing immune system. It also has effects on red blood cells and platelet cells. And then these hematopoietic stem cells, which are essentially like the seeds of the immune system, regrow the white blood cells. And it's, most people are in hospital for about 2 weeks while they engraft these new stem cells and then have very close follow-up after the procedure. There are differences in the chemotherapy used. Maybe Joachim can comment on that because that's evolved over the last sort of 20 years with different regimens which have been preferenced around the world.
So that's a good point. Most of the time we hear about HSCT as a single treatment, but in reality it's treatments that are quite different from each other, although the basic layout of the procedure is the same. So in some centers they've used very aggressive chemotherapy, which ablates the entire bone marrow. And if you don't get a hematopoietic stem cell transplantation in that setting, you will not recover and probably die from the procedure. On the positive side, this is very effective in removing the immune system, and almost all of the patients, if not all, will be in prolonged remission. And the extension of that is this dreaded word cure that is sometimes used, but often hesitantly. At the other end of the spectrum, you give cyclophosphamide in a fairly high dose, but most of the patients will recover with or without the hematopoietic stem cell transplantation. So that is more akin to a severe form of immune suppression.
So that's a fantastic overview of what's going on. I want to talk about what we know in terms of the effectiveness of the treatment, but I think while we talk about these different conditioning regimens, it's probably a good place to talk about safety in terms of that, because that's obviously been one of the biggest concerns about the use of this treatment. Where do we currently sit in terms of the safety concerns of this and things like mortality rates based on these different chemotherapy approaches that are now being used?
So I think certainly mortality rates with HSCT have improved significantly over the last 2 decades. And part of that is to do with refining patient selection, so which individuals are most likely to benefit from HSCT. I think part of that is to do with experience in different transplant centres, and certainly, I think experience of nursing staff, ward staff, but also the development of a multidisciplinary team approach. But in addition, certainly some of the improvement in mortality relates, I think, to refining the conditioning regimen. So when I first started at St Vincent's in 2017, we had been using a combination of drugs called BEAM, which is considered a myeloablative chemotherapy regimen. We've now moved towards the regimen that Joachim's team have been using, I think, the whole time, which is the cyclophosphamide and ATG, which is considered more of a lymphoablative regimen. And currently, we would quote people a mortality rate of between 0.1 to 0.3%. Is that similar to what you would be counselling patients, Joachim?
Yes, so you need to provide a number, although in Sweden, where I live, we have had no treatment-related mortality at all so far. And I think the reason for that is that we have been quite selective in treating patients who are not having progressive disease, which will mean that those types of patients will have increased risks of complications to the procedure. So that's one reason to avoid treating patients with progressive MS. And the other thing is that since now more than 15 years, we've been using this low-intensity cyclophosphamide-based conditioning regimen, which is less toxic than the more intense conditioning regimens.
And we've also seen, no deaths at our centre, but obviously this has occurred, at other centres, and I think it's important that people are aware of that small risk. And it's predominantly, I think, in the early stages related to infection, but also organ toxicity from chemotherapy, and changes in clotting and bleeding profiles. And then in the longer term, the risks of infection, persist, beyond the early post-transplant stage, but decrease as the immune system rebuilds. We have had some cases of secondary autoimmunity, far lower than the incidence of secondary autoimmunity that we see with the use of alemtuzumab. But again, cases of post-transplant thyroid disease, ITP. And I always talk to people about a theoretical risk or increased risk of long-term malignancies, although again, this is not something that we've seen in our cohort to date. And I suppose the other big one is fertility. I'd be interested, Joachim, in your centre's approach to, fertility, presumably offer fertility preservation to everyone, being referred for HSCT if they're of the appropriate age and stage.
I think that's prudent, even though it's been reported that the use of cyclophosphamide in the conditioning regimen is relatively preserving fertility, and especially in young individuals. and most of the young women and men that we're treating, they have not started their family building yet. So in that case, it may be extra important to do fertility preserving procedures. But on the other hand, they have larger ovarian reserve and will recover better from the procedure. I think the patients at highest risk of having fertility problems are those that are approaching the menopause. And if they don't have a family already, then that could be a significant reason to abstain from the procedure.
I want to move on to talk about what clinical trial data has shown us in terms of the effectiveness of this treatment. But I think one of the things that's already come out really clearly from your responses is the importance of patient selection in using this treatment. And I think that's really important when we talk about clinical trial data, because one of the biggest issues previously with this is when we've compared clinical trial data that may have used, a wide range of different patients, where now we know that we wouldn't expect to see the same response in them. So in terms of talking about this, can we talk about what that latest clinical trial data is, but also in terms of who we now think are the people most likely to respond, and who are the patients who are less likely to see long-term benefits from this treatment?
It's a not so straightforward question to answer. So one important issue is that the individuals participating in clinical trials are very different today compared to 10 years ago, 20 years ago, or 30 years ago. And that is also reflected in the trials of AHSCT, for example. So the only completed randomized control trial for AHSCT is the MIST trial, where the comparator was a practical choice that you could use whatever drug is approved by the local authorities. So in essence, drugs like natalizumab or fingolimod or dimethyl fumarate and so on. On the downside, this practical control arm means that it's very difficult to sort out the individual differences between HSCT and different drugs. Nevertheless, more than 40% of the patients in the control arm of the MIST trial were put on natalizumab, and the effects, the efficacy is fairly similar when we look at the patients that got natalizumab and compare that to the rest of the individuals. And I think that reflects the aggressiveness of the disease of the patients that were included. This is a now almost 15-year-old trial, so those type of patients which have several relapses in 1 year, they are not so easy to find anymore, because we have other effective tools that we usually pull out from our toolbox quite early now. So if someone is having breakthrough disease or a very aggressive presentation, we do not hesitate to put them on natalizumab directly, or ocrelizumab, or some other anti-CD20 depleting agent.
Jen, anything you want to add on to that from your experience?
Yeah, no, certainly. I mean, even in the sort of nearly 10 years that I've been working in this space, we have updated our inclusion criteria for our centre, really refining patient selection to focus on people who have got active relapsing disease. We have got increasing evidence that demonstrates that HSCT does not have a direct benefit on progression. And at this stage, we're still focusing on people who have had disease activity despite being on high efficacy therapy. I think it will be interesting. There are currently 4 clinical trials either recruiting or who are in the follow-up phase, looking at how HSCT compares to current available high efficacy therapy, so more restrictive than the comparator arm from the MIST trial. And I think it will be interesting with the publication of those data to see how, approaches for HSCT change. At the moment, as I said, it's used kind of as a second-line therapy or, often third or fourth-line therapy for people who are refractory to mainstream pharmacotherapy. And we have not, at our centre, transplanted anyone who is treatment naive, but certainly with our approach, in general in MS management, moving towards this induction therapy, high-efficacy therapy early on, I think we may start to see more of that. I believe, Joachim, you guys have transplanted, a proportion of treatment-naive patients, and they seem to do very, very well in terms of, improvements even in EDSS. Is that fair?
Yeah, I think that's a fair description. I mean, when you treat patients who have not tried anything else, you're always thinking what would have happened if I put them on, let's say, B-cell depleting agent, and maybe they would have fared as well if they got that treatment. But what we typically see is that if we treat them early, the responses tend to be better. And particularly for patients with significant disability at onset, we do require them to be in the relapsing remitting phase, but I think we all have encountered patients who have, let's say, EDSS 3 already from the point when you meet them the first time in the outpatient clinic. And then my sort of general impression is that if you use regular drugs, the patients will stabilize and sometimes get a little bit better, and especially if you look over long periods of time, you can see sort of a trend towards a little bit of improvement. But it takes a long time, and it's not always going to happen either. Whereas if you try HSCT, a significant portion of those patients will actually improve in disability, and some of them will have so low degrees of disability that our standard instruments of capturing it, like the EDSS, for example, will not give any result. I'm not saying that they don't have any symptoms. I'm just telling you that they got a lot better.
So I want to come back to, I think, the topic of where this fits into the treatment landscape moving forward is a really interesting one, and I want to finish with that. But before we get to that, do we have any new data around really the mechanisms of action as to how HSCT may be giving benefits? Obviously, we've always talked about it as essentially being a bit of an immune reset, an immune reboot. Is that still the case? Do we have any more details specifically about what might be happening?
We have some interesting data. So from our investigations into risk factors of getting inflammatory relapses, relapses with new MRI lesions and gadolinium enhancement and so on, we have shown that if you were pre-treated with rituximab, then you have a 5 times higher chance of remaining free from relapses and new MRI lesions. So that tells us that if we can get rid of the B cells prior to the HSCT procedure, the outcome will be better, and that highlights those B cells as something important. And conversely, if we could measure EBV replication in the blood after the actual transplant, then the risk of getting inflammatory relapses is a little bit higher. And I think it's probably due to that we have pathological B cells which are infected with IBV in the circulation remaining after HSCT, and they will sort of trigger the inflammatory disease once more. And it's probably sort of an inverse relationship between those findings of EBV and prior rituximab treatment. I know that Dr. Massey also has worked quite extensively with investigating EBV in this setting. Maybe you want to tell us a little bit more about that.
My hypothesis probably mirrors, what you're saying, and certainly the work from your group, has been very nice and very clear in demonstrating that. I mean, I think it's interesting. Is this purely kind of unregulated B cells that are, propagating this pathway? And the relationship between T and B cells after HSCT is really interesting because there's some work that we've contributed to, but also with colleagues from the UK, and this was published out of the German colleagues have looked at T cell responses after HSCT, and we seem to see better clinical outcomes in people who have diversification of their T cell repertoire, including their EBV-specific T cell repertoire after HSCT. And so it's plausible that, this re-exposure in a naive immune system to EBV, which then promotes almost kind of akin to a vaccine response, the diversification and proliferation of T cells in response to EBV may have a role in either controlling these B cells and preventing these, detectable lytic virus, which seems to be a poor prognostic factor in the Swedish cohort. But I think there's still more to kind of uncover about this interplay between virus and immunity.
Yeah, definitely. I think there's some interesting results there and stuff that's still further to unpack, but we may be starting to see some other reasons why we're getting benefits from this treatment. I think to finish with, we sort of already touched on it, but I'm really interested to hear both of your thoughts in terms of how you see HSCT fitting into treatment plan for people living with MS. Do you see a potential in the future where this may be presented as an option for a first-line treatment approach, or do you think more likely it will continue to fit into a realm where it's for people who have failed one or two existing high-efficacy therapies?
Well, I think that the number of patients that qualify for first-line treatment is very low, but it's not zero. So there will be patients who have poor prognostic factors that will not do well on conventional treatment. And for those individuals, you can present this as one option, and then you can discuss benefits and you can discuss risks. Then it's really up for the patient to decide what's best for them, and if they think that this is an avenue that they want to proceed with. But for the vast majority of the patients, it will be a second-line option or maybe even third-line option. So if you don't have all these prognostically poor prognostically factors, then you are probably better off trying something else first that may prove to be equally beneficial in your current situation. So this again highlights the patient selection. So not all treatments are right treatments for everyone. We need to look at the individual patient and try to understand what will work for this patient. And if the answer is that probably nothing else than HSCT, then you can use it as a first-line treatment. But if the answer is, well, we're as likely to reach a similar conclusion if we do rituximab or ocrelizumab or natalizumab or some of the approved drugs, then we should try that first. That's my take on it. What do you think, Dr. Massey?
No, absolutely. I mean, I think at the moment, as I said, our experience has been purely in patients with refractory disease. I think I can think off the top of my head, even just from clinic today, of many, a couple of individuals who I think this would be an appropriate and highly effective therapy for. Certainly, it's a very cost-effective therapy. The majority of patients remain off maintenance immunotherapy for, the duration of follow-up, 5, 6, 7, 8, 9 years, and probably longer in many cases. I think it's about how you, I suppose, disperse risk. And so obviously with HSCT, we're front-loading risk, and some of that risk can be pretty serious. We touched on the issue around fertility, and other longer-term complications. And it's not to say those risks don't exist with other therapies. They obviously do, but so I think we still have to be very selective about individuals. But I think, this will come sort of on par with other high efficacy therapies once we have more of these published randomized studies in the next couple of years.
Can I finish with one last question, which is going to be almost impossible, difficult to answer and I guess somewhat controversial, but I think with that being the case in terms of how we're going to use this treatment. How do you see neurologists dealing with the, I guess, continued risks associated with medical tourism? We know that this has certainly been an issue in the AHSCT space, where we've had people living with MS who, regardless of what their advice has been, want to travel overseas to areas where they can receive this treatment through commercial means, which have varying levels of risk and efficacy associated with them. Where, while this continues to sit as, potentially a second-line treatment, and understandably so, how do we go about having those conversations with those patients who are desperate to have it, to try and avoid those dangers that may come with some of those travels? Yeah.
I mean, I think one pattern that tends to reemerge is, I think we know what doesn't work. And I think that's, a blatant, hard and fast, no, that's not for you, without any explanation of why. Because, the bulk of cases I think that we still see, at least within Australia, is people who have got progressive disease, who, have been told that they're not going to benefit from HSCT, but without, I suppose, a very clear explanation as to why. And that's hard because, a lot of neurologists don't have the experience. And so I think, my personal, I suppose, plea is that, I would be, I think many of us would be always happy to discuss the rationale behind the treatment, why it's effective in certain situations and not in others. And I think information is the key there. So, that's not to say it's going to, I can still understand where many people come from. You have a disease that's progressing without, outside of your control. And I think many people will say, even if it's not going to do anything, I still want to take the risk. That's very different to us, our opinion, which is we only want to offer therapy when they know that there is direct benefit. And so, but I think discussions around how HSCT works, what our evidence to date shows, is helpful.
I just add to that, not uncommon situation is that individuals who, despite our counsel, went abroad and did the HSCT at some other center, when they come back, they are still our patients, I think, and we need to care for them, and we need to do follow-up and so on. And I do know that in some places, the physicians do not want to have anything to do with the patients who went abroad and did this. And I think that's a reasonable approach, and also questionable from an ethical perspective. I mean, they are still patients and someone needs to care for them. And if they live in your area, then you are their physician and you should care for them, no matter if they went abroad and did something against your counsel.
I love both of those responses. Information, education, understanding, care, and compassion is the way that we need to handle these conversations moving forward. Look, thank you, Jennifer. Thank you, Joachim, for your time recording this podcast today. It's been a fantastic amount of information that we've covered on a really important topic that continues to be a hot topic in the field of MS.
Thank you. Thanks for having us.
Yeah, thanks for having us.
And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MStranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MStranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2024-25 ECTRIMS podcast series is supported by educational grants from educational grant providers, including Alexion AstraZeneca Rare Disease. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook and YouTube.